Hello, everybody. Good afternoon, and welcome to our second session of the Region 7 Maternal Health ECHO series, Bridging Community and Clinical Approaches. We are so excited that you're here and joining us today. So a little bit about the Kansas Health Institute. We are a nonprofit, nonpartisan educational organization based in Topeka, Kansas, and we were established in 1995 with a multi-year grant from the Kansas Health Foundation. We are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. And so we work towards this vision by providing nonpartisan information, convening crucial conversations like the ones we're having today, and facilitating learning that leads to meaningful change. And so you'll see our work involves research, policy analysis, evaluation, technical assistance, podcasts, blogs, and then educational offerings like this Echo series. It is my pleasure to pass it over to my colleague, Avanti, who will be facilitating today's session. Over to you, Avanti.
Thanks, Rebecca. Hello, everyone. My name is Avanti Chatrathi, and I am an analyst here at Kansas Health Institute, and I will be the facilitator for today's session. So today our focus is bridging community and clinical approaches. So we started with a welcome, and then we will turn it over to our didactic speaker, have a Region 7 panel discussion, and then end with a problem of practice presentation and discussion with some whole group share outs. And then finally, at the end of the session, there will be some space for cohort announcements. So if you have any events coming up, resources that you'd like to share, there will be some space at the end of the session today to do that. You'll notice that each of our sessions will follow the same basic structure. We'll start off with that brief introduction and then have a presentation by a guest speaker, followed by a panel or breakout discussion focused on the topic. And then we'll engage in this interactive case-based discussion. So this ECHO series is intentionally designed to bring together diverse voices across the maternal health space because no single sector can solve these challenges alone. So our four key participant groups as a part of this ECHO series are community members with lived experience. So that's the heart of this work. The voice of community members with lived experience shapes everything. Community organizations, trusted partners that are embedded within the communities that we serve, clinical professionals that bring that medical expertise and frontline insight, and then state level staff, state and local level staff providing that policy context and systems level perspective. So the goal of this cross-sector collaboration is to learn from one another, share what's working, and collectively strengthen maternal health equity in Region 7. So our overarching objectives of this ECHO are to use actionable strategies to engage mothers and community voice in shaping service delivery and evaluation, build networks across Region 7 to share practices, resources, and data-informed insights, leverage community-based approaches like collaboration with community health workers and doulas within clinical systems, and identify and share strategies to address region-specific maternal health barriers like access, transportation, and trauma. The series is made up of 5 sessions, which the last one will be in October. And as you can see, we are covering a broad range of topics over the coming months. Today's session is session 2, and we're focused on bridging community and clinical approaches. And while it's not a requirement that you attend each session, we do encourage that you attend as many of these sessions as possible so that we have the opportunity to get to know one another and collectively build off the learnings from one session to another. And speaking of our sessions, we wanted to give an overview of the breakout discussions that we talked about, that we had in our last session. So session 1 focused on enhancing regional collaboration and resource sharing. And instead of hosting a panel, we had breakout discussion groups by field to talk about assets, barriers, and resources each field could contribute to regional collaboration. Some of the cross-cutting themes and highlights included legislative support. So having that sustained legislative backing is essential to continuing ongoing work. Certain fields like nonprofits and community advocates can take the lead in working in the space and getting that legislative support. One of the other themes was collaboration gaps. Understanding that programs and partners often don't know what resources are already offered. And so there was a discussion about the importance of resource sharing and sharing tools across different sectors, like screenings, resources to connect patients after assessments, providing resources that are culturally congruent and responsive to certain patient populations. And then finally, the third theme that came out of these discussions were cross-sector partnerships. So recognizing that each of these sectors bring different expertise to maternal health, and partnerships can help fill those gaps and prevent duplication of existing work. And so some specific examples that came out of those discussions included MOUs between organizations, especially with organizations that have higher turnover rates. And then really leaning on that theme that each sector brings a unique role in bringing other partners to the table. This is our Ad Astra Echo planning team. So we will be on each Echo session and are kind of the backbone to running this series. And then finally, we also would like to ensure that you have access to any resources that are mentioned today so that you can continue exploring this topic. So in the chat, you'll find a resource guide PDF that contains the resources mentioned today, along with discussion questions and a note-taking space that you can use to guide your reflection on the topic or conversations within your organization. All right, and with that, I am going to introduce our didactic speaker, and then I'll turn it over to her for her slides. So our didactic speaker today is Tanya Wright. She is the CEO and founder of the nonprofit Altruism Inc., which focuses on improving maternal and infant health outcomes in Missouri and Kansas. She's also the CEO of Grace Advertising and Consulting Inc., a social enterprise that focuses on amplifying racial and health equity in rural and urban communities through advocacy, education, and outreach. She also publishes Access Health News, a monthly digital publication that underscores health policy and public health issues. Tanya, thank you so much for joining us today. We're excited to have you here with us. So I'm going to turn it over to you for your didactic presentation.
Good afternoon, everybody. And thank you for sharing this space today as we talk about bridging community and clinical approaches. Again, my name is Tanya Wright, and I am happy to be here. So we'll get right into it. All right, so who are we? In actuality, Altruism Inc. started nearly 20 years ago, although I didn't know it. In 2007, I launched Grace Advertising and Consulting Inc., which is a healthcare marketing and outreach agency. We work a lot in rural areas and in the urban core. Our mission has always been very altruistic. We often encountered organizations that had awesome missions, but zero marketing budget. And so we would work on their behalf without a fee. When COVID-19 hit, our pro bono work soared through the roof because it was so important to deliver messages about the pandemic and the vaccines that were nonpartisan to equip people with the ability to make informed decisions about their health and safety in the vaccine. So as the pandemic, came and went, we were left with a huge experience in the advocacy space. And I knew that I didn't want to stop doing work that wasn't curated, that wasn't paid for. So I said, okay, I will start a nonprofit media company that will do all the free stuff, and our for-profit will just operate as a for-profit. That was my bright idea. At the same time, I started getting inundated with maternal health statistics, because as you all know, COVID really shined a light on healthcare disparities, especially among people of color and rural people. I couldn't escape these messages. And so I literally pivoted midstream and moved from a media nonprofit to a maternal health nonprofit. In 2021, I launched Altruism Media Inc. We have since dropped media from our name. And a year later, I launched what was called the Maya Project. Maya is short for maternal and infant health. And we would deploy doulas, community health workers, and midwives to women and birthing people who struggled with access and quality care. A year later, we opened a pregnancy center, not a birth center, but a pregnancy center that's focused on doula support, community health worker support to coordinate care, and midwifery. We did that in rural Missouri. 2 years after that, we partnered with Samuel U. Rogers Medical Center. They're a federally qualified health center. We partnered with them, created an MOU, and we are currently co-located in one of their clinics in the urban core. Our why is very simple. For starters, Black women have a higher maternal mortality rate than pretty much anybody else. A Black woman with a college degree has a higher mortality rate than her white counterpart with less than a high school degree. And you can see those extremes on either end of this slide. And this, of course, is per 100,000 deaths. Another thing that we uncovered is that a woman or birthing person covered through Medicaid is 7 times more likely to have a pregnancy-associated, not related mortality rate than a counterpart with private insurance. Additionally, almost all women across the board, 45% of them, according to the CDC report, not asking questions when they're visiting their provider, not asking questions, not sharing things that happened or concerns because they simply don't have a comfort level, and that power differential is just too much for them to overcome. And in particular, women of color, 30% report mistreatment in clinical settings during labor and delivery. This is also according to the CDC. But this mistreatment and the experiences are not relegated to just women of color. And this next video kind of underscores some of what these women are experiencing.
The baby may suffer if you don't have the epidural.
Why did you even call me in here? This is the tip of the iceberg.
It's not about what you want. We are gonna follow my plan.
I'm not gonna take my hand out of you until you calm down.
If you deliver your baby at home, you and your baby will die.
Call me in 2 hours when you're ready for a C-section.
Now that I'm inside you, I'm gonna go ahead and stretch your cervix.
Do you want the husband stitch?
Why do you want a natural birth? Just to say I did it?
I'm protective of my babies, so I don't let dads catch.
Don't shout like that. You'll scare the other moms.
Water birth doesn't benefit anyone. It's just a fad.
You're not progressing as fast as we'd like you to.
You don't want Pitocin? Do you want to die? Don't you want your baby to have a mom?
I'll tell you only the things you need to know. The rest is just for the medical staff.
No, sweetie. We'd be able to tell you if you feel ready to push.
You just earned yourself a ticket to the OR.
There's no trophy for a natural birth.
I'm wiping the baby because it's ugly and nasty.
You don't need a birth plan. We are a baby-friendly hospital.
You just have a lazy uterus.
I'm not gonna stop rubbing your baby. Your pelvis is too small to ever deliver a baby naturally.
I'm not comfortable with you pushing in any position other than on your back.
I want you on your back.
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 It's hospital policy.
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 So for these reasons and so many others, we not only pivoted from media to maternal health, but we really investigated ways to bridge community with clinical approaches. We know that community peer workers like doulas, community health workers, and midwifery are game changers for women and birthing people during prenatal and postpartum. We know how important it is to collect data in a meaningful way and share it to help produce improved maternal and infant health outcomes. We also know that there are cross-sector partnerships and experts that can help us along this journey. And last but not least, we know that we have to rethink care delivery. For starters, doulas provide evidence-based benefits that can't be denied, and we have been blessed to work with health systems to help some of them embrace doulas, work with doulas, and not just tolerate them, but really see them as a valuable asset in a clinical team. And it's because they help mothers and birthing people reduce their anxiety and the emotional and emotions and fear that come with giving birth. They help increase more physiological births and reduce C-sections. What the evidence shows is that there's a decrease in labor duration and a higher propensity to be satisfied with the birthing experience. There are also higher rates of breastfeeding and fewer preterm births. And we can go on and on about the benefits of doulas and community workers, community health workers and midwifery. But these are the benefits that are most underscored. So what did we want to accomplish with our work? And we'll talk a bit more about this here in a second. So what we're doing is we actually created a 9-module curriculum. And the purpose of that curriculum was to go into health systems and help them integrate doulas into their care teams in a way that is collaborative. The doulas and the clinicians actually get to know one another. And so when they're walking in the room with their client, with the birth plan, it's not like, oh gosh, no, not another birth plan, not another doula, but it's literally a collaboration. So this 9-module curriculum covers everything from, unconscious bias to the legwork that it will actually take in that particular health system to integrate those doulas into those care teams. We know this is important, and what we're learning is that systems change and maternal health equity can't happen in a vacuum. When we coalesce community and clinical, what we get in return are improved maternal health outcomes. We are learning. We don't have it figured out and probably never will. But the beauty of all of this is our willingness to work together, to sit in the tension sometimes, and to be honest about the barriers. So here are a few things that we're learning. And as this unfurls, gosh, there'll be so much more to share about what we uncovered. So we're learning that when we start these relationships with peer community experts, because doulas and community health workers and midwives are experts, when we start this relationship with them from both a clinical standpoint and a community standpoint, it's okay to acknowledge that power differential that has historically existed during labor and delivery, prenatal visits, as you've seen. It does shape access to care and quality of care. So we're walking in, acknowledging the assumptions, And we instead are looking at a community-informed approach as opposed to just a physician-centered approach. We can't negate the value that doctors and nurses bring, but when we coalesce the physician's expertise with a community-informed approach, the desired outcomes that we seek are actually more realistic to achieve. We know that the primary goal is to deliver a very equitable experience and to allow that birthing person, that woman, during labor and delivery and during her prenatal and postpartum journey to have that autonomy over her body and the ability to provide input on what that person deems important. We know that the intervention focus also needs to include upstream knowledge, which means that certain bodies aren't made naturally inferior, that there are historic and systemic challenges that some people face that increases their likelihood for at-risk outcomes. It's not necessarily an individual behavior or a proximal cause. There are systemic barriers that folks face that circumvent health equity. Having access to community experts truly enables this bridging to be engaged, collaborative, and there's reciprocity. There are some things that doulas also have to learn as well. For instance, a hospital system's protocol, when things don't go as planned during labor and delivery, and everything is on its head and things have to move fast. So those are things that we are working through as we work to integrate doulas into care teams. And last but not least, we can't do this without each other. We can't achieve the maternal and infant health outcomes that we speak about on an island. It requires all of community to step in with their expertise to really support this effort. And as we continue this journey, we are learning as we go. But one thing that we do know is that when we integrate doulas into care teams, the outcomes are better for not only the clinician, but most importantly for that birthing person, that woman and their family. Thank you. If there are any questions, if there are any time for questions, I'm happy to answer any questions.
Yeah, thank you, Tanya. I think if anybody has any questions, please feel free to put them in the chat. Maybe before we move on, Tanya, I might ask one question of you. What if you, thinking through, you had this, last decade or almost 20 years of strengthening these community clinical partnerships. What is one piece of practical advice that you'd give someone who wants to start or strengthen a community clinical partnership?
Asking questions and listening, not with just your ears, but your heart.
Yeah.
Because this is heart work. And it's so critical. And, with all of the wonderful physicians and nurses that we can all name and picture and celebrate, we have to be honest about the fact that this system is broken. And so it's having the ability to truly listen, to sit in the tension sometimes, to ask hard questions, to research, to find folks that aren't necessarily like-minded, but individuals that can help collectively chart a better path. When we started this venture with one of the health systems that we're working with, it wasn't a welcoming, feeling at first. There was some pushback, like, you're going to force us to deal with doulas and integrate doulas. It wasn't an easy process. It took a year and a half to disarm and to get folks to a place where this was something that they embraced and realized was needed and could perceive the benefits.
Thank you. Thank you for sharing. And I think, that's one theme that we're seeing with when we're talking about working with community is that long-term commitment and that ability to build trust over time. So I appreciate you sharing today, and I thank you so much for joining us today. And if anybody else has any questions for Tanya, please feel free to put them in the chat and we can get them to her after this presentation. All right. With that, we are going to move into our Region 7 panel discussion. So I am going to briefly introduce the panel and then we'll start our discussion. So I am going to start with introducing our first speaker. Our first panel speaker is Abriana Markham. She is the executive director of the Topeka Doula Project. She is a researcher, a reproductive justice advocate, and the executive director of the Topeka Doula Project. Rooted in direct community work and her own personal experiences, her journey into birth work began with a passion for lactation equity. Driven by a commitment to systemic change in maternal health equity, she certified as a doula in 2022 to actively combat the Black maternal mortality crisis in Kansas. A significant portion of her career is dedicated to serving incarcerated patients at the Topeka Correctional Facility, where she provides trauma-informed doula support. At the heart of Abriana's work is a deep belief in the power of community care, dedicating herself to listening to marginalized families and providing them with the tools to turn their collective pain into power. And then I also want to mention today is her birthday, so we really appreciate her joining us as a panel speaker for our session on her birthday. So feel free to wish her a happy birthday in the chat. Our second panel speaker is Amber Goodrich. She is a certified nurse midwife, clinical associate professor in the Department of Obstetrics and Gynecology at the University of Iowa Carver College of Medicine. And she's also the division director of midwifery at University of Iowa Healthcare. Her work focuses on strengthening maternal health outcomes by bridging community-informed care with clinical practice in complex health systems environments. Since 2021, she has led the expansion and transformation of midwifery services at the University of Iowa, doubling the division's number of midwives, expanding care across 6 clinical sites to bridge the rural healthcare gap that has been created due to multiple labor and delivery units closing, and opening a second labor and delivery unit centered on low-risk physiologic birth. She has helped implement innovative patient-centered practice designed to improve access, choice, and equity in maternity care. She's also the lead faculty member in the development and implementation of Iowa's first nurse midwifery education program launched in 2023. Her leadership emphasizes collaboration with doulas, community organizations, and public health partners, and interdisciplinary care teams to ensure community voices are meaningfully integrated into clinical workflows. And finally, our third panel speaker is Stormy Griffin. She is a proud member of the Ho-Chunk tribe of Nebraska and the Thunder Clan, born and raised on a small reservation where she witnessed firsthand the need for Native representation in healthcare. Driven by a passion for serving Indigenous communities, she earned a degree in Indigenous Health Sciences, an associate degree in nursing, and a bachelor's of science in nursing. Since becoming a nurse in 2019, Stormy has worked with the 12 Clans Unity Hospital in Winnebago Public Health Department, dedicating her career to improving health and well-being of all tribal members. Her primary focus has been at advancing maternal and child health outcomes, improving infant health, and providing specialized breastfeeding education and support. Through compassionate, culturally responsive care, she remains committed to strengthening the health of Native families and future generations. So thank you all for joining us. We're excited to have representation from different states and different sectors working to improve maternal health outcomes. And I'm going to go ahead and stop my screen share for our panel discussion. So I'm going to start with a question for Abriana. So your work has centered on direct community work and systemic change to maternal health care. How can clinical teams better work or better welcome doulas into care workflows without stripping away the essential community first identity?
Thank you for this question. And thank you so much, everybody in the chat, for the happy birthdays. But thank you for this question. If we want to talk about welcoming doulas into care workflows, clinical settings, I think we have to start with being honest. And that is the respect in the clinical setting is currently conditional because doulas are non-medical. Systems often assume that we don't hold expertise in the room and that we are simply just a body there to fight against what they are trying to do. But in actuality, we're trying to make sure that our client is informed. And so if the clinical system or our health systems often operate under the assumption that a hospital is inherently a safe place, but they haven't fully, I don't think they fully reckoned with the historical and ongoing harm that hospitals have done to communities, especially to strategically underserved communities. Labor and delivery also isn't automatically viewed as a safe place to ask for help or disclose vulnerabilities. And so I think when we bridge the gap between both the clinical setting and the community, doulas are a big part of that. And I think we're a big part of that because there's a couple examples that I wanted to make sure I talked about today. And it was, I had a client who was asked her social determinants of health screening questions that the hospital asked during the intake session. She answered no to everything, said everything was fine, but I knew for a fact she was food insecure, housing was unstable, and also bills were stressing her out. But that's not my job to then air out that she needs all of these things. My job is to quietly hold space for her and support her in terms that make sense for her. Because right now it wasn't a place where we can talk about her needs. That's not what she wanted to handle at this moment. And I think sometimes hospitals have to understand that, oh, okay, everything seems fine, everything's good. And so that's how you move on for the next 12-hour shift as a nurse or the next 24-hour shifts as a doctor. And then I have to, make that note of, okay, what resources have we connected them to get those social determinant health factors met or fill in those gaps per se. I had another doula colleague of mine who we talk about stories all the time, and she had one where she knew the client was having some intimate partner violence in the home. And so when they're asked the standard abuse questions, again, I'm fine, everything's good, no need to worry. And again, we hold that space silently and we make sure that we are taking note and writing down the things to help them because those are things we're dealing with. We're here at this hospital to give birth to a baby. And so a lot of times, even if there are resources that the hospital can provide, the community doesn't feel like this is a safe place to even say that I need help. And so I think we have to first reckon with the fact that the hospital is a place where we go for help, but not a lot of people seek help there intentionally if it's not for a broken bone or an ache or a pain or labor and delivery. So I think we have to be honest about that. I think that's one thing that we have to talk about, but also moving doulas into workflows. Doulas can't do this by ourselves, but doulas are not here to become mini hospital staff positions. We're not here to become nurses. We're not here to become a part of the system that we are trying to slowly unbraid and take away. And so I think the second a doula is viewed as an extension of the system, we will slowly evaporate the community trust that we build and work so hard to intentionally create. Our power comes from being independent, community first advocates. We aren't checking off billing boxes first, of how we can do something or how does this get us paid or how do we end up with this. Our goal is to make sure these families have what they need and we are building human relationships and we're building community within our network of folks. And so I always say I wish every family had their own doula so that they could go in and advocate for them or not even for them, but with them in a way that makes sense for them and on their terms. And so I think that something else the clinical system has to also take into consideration is that we are given a space to work, but not always welcomed. And sometimes that is a direct reflection of what they feel like the what they feel of the community. So if the doula is a community person and we're asking doulas all these questions and what to do, we have to also do better at making sure our doulas aren't there just so that we can absorb answers and get data from them. But we're actually intentionally building relationships with doulas to build relationships with the community. Because when we trust the community, then we can trust the doulas. But we're often, and I say we because I'm a doula, and so we are often mirrors of how the system treats the community as less than, as a second thought, as I know best, listen to me. And so that's why I love that video that Tanya has shared. I share that video all of the time with so many people because I need people to understand that sometimes these small sentences is what reflects of what we think about our communities. Another example is even my personal experience. I had a COVID baby. So 2020, nobody's allowed in the hospital except me and my husband. We have a baby. It was 2 o'clock in the morning. We had been there all day in induction. And so I am ready to give birth to my child. I tell them to wake my husband up. And he jumps up and goes, "Oh my gosh, are we having a baby?" And the doctor literally tells him, "With or without you." And that kind of rubbed me the wrong way because what do you mean without him? Without him, we wouldn't be here. Without him, this would not exist. I would not be pregnant. So he needs to be a part of this just as much as I am. And so even though she didn't mean any harm by just saying with or without you, what it does is it unintentionally creates harm, and it creates well, what do you mean by that? Because we need him to be here. And so being a direct reflection of the community and also how the community is treated. We say, people with lived experience are experts. They're experts. And we want their information. We want to figure out how to help. But I think what we forget is that communities, especially strategically underserved communities, are inherently communal. They have been helping each other and themselves for before hospital systems existed. And so leaning on them as an expert truly means listening to them, and not because they don't have the alphabet soup behind their name, but because simply they are a human being who knows something about the community that they serve. And that echoes for doulas and those things as well. And I think we have to be honest with ourselves and acknowledge that institutional harm does happen, whether intentionally or unintentionally. And we have to strive to make sure that we are not silencing things that are often seen we are not silencing things that the community has used for survival for years. Okay. And so clinical teams have to make sure that they know that this doula is probably coming from this community, and if not, has spent so much time with this community. We have learned their morals, their values, and what's important to them with birth. And we are not to be pushed aside or second guessed, but we are there to slow things down. And so I encourage the system. So as I close, I do encourage our clinical system to be more aware of their own bias and the things that they have and the things that they say. And while they might come off, like I said, unintentionally, not harmful, they do cause harm. And so just listening, and I think as people, we have to do better at active listening and making sure we are listening to hear and not listening to figure out what can we say next, or how can we debunk what this person is saying. I had to tell a nurse, and I'm not going to go back and forth with her because she was simply just trying to debunk what I'm saying, but forgot that our eyes need to be on this client because this is not what this is about at this moment. So to wrap up, understanding that doulas deserve the respect in the clinical space because not only are we informed advocates, but we are people who are sitting next to people and rubbing shoulders with people. We go to the same grocery stores as a lot of these people. I'm pretty sure the OBGYNs, they do not go to the same grocery stores as a lot of their clients that they serve. And so when we're asking them to do certain things or eat certain things, I can tell them, hey, make sure you go down aisle 12 and I know they have this and that and you can get that because I simply live, sleep, and eat exactly where my clients. And so I think that alone should be integrated into the system in a way that is helpful, and builds community and trust. And then once community sees that our system is trusting the doulas, the person that they brought in using their autonomy, it's also a great way for them to see, oh, that my voice can be respected in this room as well. Because a doula's job is also to be quiet in the room and let the family talk and have their moment. And so if you give us that respect, then you ultimately are giving that family that respect to do and say what they need to do so that we can not unintentionally cause harm. So that is all. I will leave it open for questions or thoughts.
Yeah, if anybody has questions for Abriana, please put them in the chat. I'm gonna pivot to our other panel speaker, and then we'll come back to questions after each of our speakers have had the chance to go. But kind of building off of integrating doulas as an extension of the community into healthcare. I wanted to turn it to you, Amber. So you have had this experience of kind of extending healthcare to communities in need based off of community need. So could you talk a little bit about your experience leading midwifery and maternal health teams and how you've successfully operationalized community partnerships so that they're embedded in those clinical workflows?
Yeah, sure. So I realized that as a certified nurse midwife, the laws are different in Iowa than what they probably are in Missouri versus Kansas. But I'm a certified nurse midwife in Iowa. I am an independent practitioner. I actually have admitting privileges at the hospital here, that one of the hospitals that we deliver at. And so it is a little bit unique, I realize, compared to other institutions. However, I think the University of Iowa has really done a great job of integrating midwifery care within the system. And one thing that they have used us for is to help bridge the maternal health care gap. So I can't take credit for this, but I do want to mention we hear so often the term maternity care desert. And I recently heard a speaker that say, but it's not a desert. A desert is a naturally occurring phenomenon. These maternity care deserts are places that we don't have care in rural healthcare have happened because of a lot of different things, social disparities, different insurance payments decreasing, etc. But the University of Iowa, we knew that we had to help with that. So we've had I don't know the number off the top of my head. I want to say it's around 50 labor and delivery units just within the last 10 to 15 years close in Iowa. And unfortunately, that affects typically people of color, people who don't have transportation, people who don't have jobs, people don't have people to take care of their children. So without having that local health care, they're not going to get care. And so and they also often have to travel 1 to 2 hours to even get care. So we decided, you know what? Let's go to them. So we developed what we call a spoken hub model were we developed a relationship with one of the hospitals that closed about an hour south of us, and we were able to utilize their space to see our patients in the clinic. We go there twice a week. We utilize their ultrasound, and we also utilize their lab services. And then those patients come to Iowa City just to deliver their baby. So it decreases the amount of time that they spend traveling. And I think we've had really amazing outcomes from it, not just by patients, but also the patient trust and the patient care, but also the midwives really enjoy going there and connecting with those patients and getting to know them. And then a few years ago, we have the big university hospital that has all the things that you need, but within our community, there's also a smaller hospital that is meant to provide a service to patients who don't want to deliver in an academic setting. Like maybe that's intimidating to them, too big. Maybe they have a different reason why. But the midwives work to keep that open, and we were able to do that here because we take care of most of the low-risk patients. And I think that collaborative model works really well, and our outcomes have really spoken for it. We have consistently like about a 13-14% NTSV C-section rate, so a very low rate compared to the national average of around 30%. We've been able to listen to our patients and also integrate things like we have a doula program that we trained community doulas for free through a grant, and then had them work with us the first nurse midwifery education program so that we can then work to develop more midwives to hopefully stay in rural areas, specifically in the Midwest. So That's some of the work that I'm doing. I just want to really point out though that we're not competing with other hospital systems. We're strategically choosing where to go based on who needs access. So we're not taking from the pie, we're making a new pie. And I really would hope to inspire and connect and network with other big hospital systems, maybe in Missouri or Kansas, that might feel pulled to do this work, because I do think it takes the bigger hospital systems to be able to like financially back it initially, but then what we've found is the reward has really paid off.
Thank you, Amber. Thank you for sharing. And I think that's a the powerful examples and powerful examples of how hospitals can be involved in this work and have that community informed approach. Stormy, I want to turn it over to you. Just you work on the public health side of things, work with the health department. So really wanted to get your perspective as because health departments often sit at that intersection of community and clinical systems. So from your experience, what has helped you build trust with the community that you serve, and how has that shaped collaboration with clinical partners?
I just want to start off by saying Hanat Chanikarigiwi, Maikate Rajara, Stormy Griffinga, Hingaire, Wakanja, Hiwingiwinga, Hingaire. I greet you all. My English name is Stormy Griffin, and my Ho-Chunk name translates to Queen Thunderbird. I just wanted to thank everybody so far. I've already learned a lot, and that's been really exciting. So one thing kind of unique about me is I have been born and raised, like I said in my bio here. So my trust might already essentially be established just because I know just about everybody here. But one thing that I've built for the people that I don't know is being consistent, approachable in the community, having an open door policy, being willing to do home visits, community events, school health activities, working with families one-on-one. I found that people are more willing to engage when you see that you're actively listening to them, following through on commitments and respecting their experiences and cultural values. A huge asset that I've been able to bring to this maternal child health space is the fact that I am Ho-Chunk and I'm serving a predominantly Ho-Chunk community. For those, I know we're kind of from all over, but I'm from Winnebago, Nebraska, and I believe there's only 4 federally recognized tribes in the state of Nebraska. So we get a lot of array of different Native Americans that we serve in our community. As a maternal child health nurse, I work very closely with our primary care clinic, and building trust also means meeting people where they are, both physically, emotionally, and spiritually, taking the time to understand a family's concerns before discussing recommendation creates a partnership that isn't just a one-sided interaction. When community members feel heard and respected, they are more likely to seek services, share concerns, and participate in public health initiatives. The Winnebago The Winnebago Comprehensive Healthcare System is truly a comprehensive healthcare system. So we have a health department, and then above us is the main hospital. So we work really closely together, and an example of that would be our prenatal care. So when our ladies get a confirmation of pregnancy, I put together a bag for them that has everything in it regarding prenatal services, resources, different things that I'm able to help them with. And then the primary care providers give it to them. And then at 36 weeks, I also provide them like a diaper bag that has information in it. And then they do come and see me. I run the Maternal Child Health Grant out of the state of Nebraska, basically helping with maternal and infant mortality rates amongst Native women, because we share the same statistics as other women of color, unfortunately. So bridging that and trying to, me and the primary healthcare provider, they do public speaking at our events. So it's really unique to a lot of the community members get to see their actual primary care provider doing educational classes around the community. And that trust has strengthened collaboration between us. Community relationships often provide valuable insight into barriers that patients face, such as transportation, housing, access to care, or health literacy. And then over time, our clinical partners have become increasingly involved in the community, which hasn't always been the case for us. The health department in itself is constantly growing. I'm pretty excited to see just about all of us are starting to roll out doulas. We, in particular, have Indigenous doulas. So that's an Indigenous-based program that is just for Native providers. And so that just started in May. So I've been working closely with them to help them get their program up off the ground, providing them resources and different things that I can help with. So basically, I'm like a one-man team, but I run it efficiently and try to basically reach anybody that I possibly can. But yeah, so we work really well together. I wouldn't say it hasn't always been that way, but recently a lot of change in administration and everything has really allowed us to have that close connection with each other. The shared experiences in the community helps build trust, improve communication, and allows us to better address the needs of the people that we serve. By working together, we provide a coordinated patient-centered care that benefits both the individual patients and the overall health of our community. But I do realize that we are like a little world, and then I know a lot of people are like in big cities and stuff, so we have the autonomy to do very specific things that a lot of other places don't have the opportunity to do. So sometimes I get a little hesitant about going on speaking panels and stuff because I realize my world is nowhere near like the different struggles that other people face. Like for instance, if my patient needed a ride here, I can call someone immediately, get them a ride here. I can, if they needed something, I can find a way to get it. Like it's just not something that is normally seen all the time. So, but yeah, so we're really fortunate in everything that we can provide and that our health department is constantly growing to meet the needs of our growing community. So thank you guys.
Thank you. Thank you for sharing. And I think we have time for one more question. So I want to see if there's any questions from the audience. And while we wait, I might go ahead and ask one. You all have kind of touched on this idea of trust and building trust with communities in need, and that how that takes time. That takes that time and that effort. So I guess my question is around that, like because that trust building takes time, how do you keep communities engaged, whether that's the patients that are coming to see you or they're coming to your systems for healthcare, or the partners that you're trying to get to support the work or the partners that are supporting the work? How do you continue that or continue to get all those different sectors, partners involved to make sure that you're able to keep building that trust, provide the best care for the patients that need it? And anyone feel free to jump in. I know I changed the question a little bit, so you can also take a little bit of time to think about your answer.
I thought you were gonna go. I would say advocacy is a big one for me, making sure that I advocate for my patients in any way that I possibly can, listening to them. Like I said, I have an open door policy, so I try to garner that, and like word of mouth really works well. Being a small community and the resources that we're able to provide. So just really listening and being present in the moment, not listening just to respond or hurry up and get them out of there, but really listening so that way they feel seen and feel heard. Because and I know that I speak for a lot of us when we all know what that feels like when somebody is just like listening us so that way we can hurry up and get out of the appointment or hurry up and leave basically, but really listening so that way they feel that they can trust us and that we're actually there for them.
I also think just showing up and being consistent and, walking the walk. If you say you're going to do something, doing it. And oftentimes it just takes time. But if you see that like the results are consistent. I know, for example, when developing relationships with our home birth midwives, they're seeing that consistently. You know, they're getting safe care, respectful maternity care when they transfer in. And then before you know it, word of mouth happens and that trust continues. So.
And then, hey, Brianna, I want to give you a chance if you want to answer, but if not, it's totally fine too.
No, yeah, I'll just echo the other two. I think it's literally showing up and doing what you said you're going to do. A lot of times, because I run a nonprofit, nonprofits we are great at doing pilot programs and starting something new, but sometimes what works works. And being able to maintain what is working and how you filling in the back gaps, I think that shows the community that, okay, this is here to stay and I have something to depend on, or that I can use until I don't need it. And then, yeah, word of mouth.
Thank you all. All of the work that you're doing, it all sounds amazing. I really appreciate you all coming here today and speaking on our panel. And if anybody has any questions for our panelists, feel free to put them in the chat and we can get them to them after this session. But I think we'll go ahead and move on to our next section. But just thank you, a round of applause for you and for Tanya. You guys gave some great information and shared some great stories. So yeah, thank you again for joining us. I'll turn it over to Rebecca for the next steps.
Awesome. Thank you, Avanti. And a big thank you to everybody who joined us today, from our speakers to cohort participants, facilitators, the Ad Astra Echo planning team. This is a really great collaborative effort to bring together lots of expertise, perspectives, insights, and just knowledge and experiences around this topic. So we really appreciate your time and dedication to this. And what I'll be doing is sharing a few additional resources and some information about continuing education credits and what you can expect coming up. You will see this link in the chat. This will also be in the iEcho platform under the content tab when you go into the program there. This is something that we encourage you to use, access, look at the different resources there from KCHI, but also speakers. And share it with others. This is really meant to be something that you can circulate and pass along to others who might be interested. Just a reminder, kchi.org has lots of other resources, so we encourage you to check those out, like publications, interactive dashboards, and other events. And we just want to say a big thank you again for spending this time with us. We really appreciate it. We find it very engaging and exciting to be able to connect with you and learn from you throughout this series. So we hope to see you on August 25th, and feel free to reach out if you have any questions in the meantime. Thank you again. Have a great day.